surgeon in the UK. Just waiting to see if it contacts.
Hello.
Hello, Richard. How are you doing?
I'm good. How are you?
Excellent, my friend. We can't see you, but hopefully you can see us.
I can see you. It's a bit pixelated, but I'm just trying to work out why you can't see me. You should be able to.
Not a problem, my friend. So what we'll do, I'll just bring up your presentation. So Richard, what I was doing is just letting these chaps know a little bit about you. This is Richard Hind, Mr. Richard Hind. In the UK, what we have is surgeons are called Mr. and physicians are Doctor. Mr. Richard Hind was one of our lead clinicians leading the hospital, and then he decided to actually come back into the fold of normal working. He's a very, very good friend, but he's also a very straightforward talking individual. And so don't be frightened of asking him questions. These chaps are a little bit shy, Richard, but what I've brought up is your first slide, which is about that. Is there anything you want me to add, my friend?
No, I'm quite happy with that.
Excellent.
You're okay with that? You're okay without being able to see me, are you?
Yeah, there's not a problem, my friend. I mean, I see enough of you when I see you at work, so seeing you now is not really going to help me.
Thank you very much.
So, case presentation.
So shall I kick off?
Yes, please.
Yeah. So you got the title slide up, have you?
Title slide is up.
Then
Yeah.
Essentially, what I wanted to say was just how we've been following up patients post colorectal cancer surgery, but also raise one or two other issues that will hopefully get you thinking with a view to sort of teamwork. As Paul said, we do work very closely together, both as a couple of people working in the same hospital, but also as part of a multidisciplinary team. So if you put the next slide up, Paul.
Away we go.
Okay, and so the case that I wanted to highlight to you is a chap first presented back in 2002, 64-year-old male with anemia. He had a barium enema as his first investigation, which just shows how things have moved on. We very, very rare, if ever, do a barium enema these days. It would be CT rather than barium if colonoscopy doesn't work, but we're very much gold standard colonoscopy nowadays. But this demonstrated a malignant lesion in the distal transverse colon. We proceeded to a laparotomy. My original intention, because he's a young man and distal transverse colon, was to do an extended right hemicolectomy, because that reduces the amount of colon with unstable mucosa. Because with a young person, a lesion in this area, we always assume that the rest of the colon is potentially unstable. But at laparotomy, the tumour was found to be adherent to the sigmoid colon, and so I performed a left hemicolectomy instead, partly because if we'd just resected the right colon at this stage, he would have ended up with an ileorectal anastomosis, and as I'll come on to a little bit later, the less residual large bowel that a patient has, the poorer the function of the bowel may be. So if you move on to the next slide, Paul.
Next slide.
So as part of our initial follow-up for that one particular tumour, we performed CT scans at 1 year, 3 year and 5 years, the 5th year only if they have chemotherapy. But all of his CT scans were all clear. So at the 5-year mark, we discharged from follow-up in the surgical clinic, but we continue with a colonoscopic surveillance program. At this stage, we were advising 5-yearly colonoscopies, and as you can see there, in November 2007, his surveillance colonoscopy was completely clear, and a repeat was requested for 5 years later. So we can move on again, Paul.
Next slide.
And here you see an image from the decum on his scope that was performed in December 2012, which shows this polypoid lesion within the cecum. Quite nice. If you move on to the next one, Paul.
Next slide.
Unfortunately, we don't have any further images at that stage, but the polyp was lifted. It was excised. Endoscopically, it was felt to be complete, and we think it's very important for the endoscopist to comment on completeness of resection, which again I'll come on to shortly. Histology showed a 15mm lesion, which was a low-grade tubular villus adenoma, which had also histologically been completely removed. Because of the size of the polyp, our polyp surveillance program, so there is a bit of overlap here, but our polyp surveillance with a single polyp over a centimetre in diameter, we would repeat a colonoscopy 3 years later. So that's what he had performed. And here we see January 2016, so 3 years further on, he has another large cecal polyp, which is somewhat more sessile than the first one. And I don't, at the 6 o'clock position on the screen there, you can actually see it sort of, it does look fairly flat and seems to be spreading. So there's slightly worrying features with that particular polyp. So if we move on to so the endoscopist at the time wondered if it was a recurrence of his previous polyp. I suspect it's actually a new polyp, because the original one was both endoscopically and histologically felt to be completely excised. So I think this is another polyp again. So it's looking very much like his cecum, the mucosa is quite unstable. This particular polyp was lifted and it was removed piecemeal, which is often the case with a polyp of that size and being that sessile. Histology showed it to be a low-grade tubular adenoma, and because of the fact that it was spread and removed piecemeal, it was felt that the polyp site should be checked around about 3 months later. So if we move on to the next slide, Paul.
Next slide.
And this image shows the area at the end of excision of that polyp that's been removed piecemeal. So it appears to be clear, but because of the piecemeal nature, it was felt that we ought to have a look 3 months later. This was carried out at the end of April in 2016, when a further 12mm polyp at the same site was noted. This was lifted, removed piecemeal, but endoscopically felt to be complete. And I think this is the one that you did yourself, Paul.
It was, yeah.
And you suggested that we ought to have another look 3-4 months later with myself present, so that we could actually look at this together, just in case there was going to be a further problem. And the slightly more worrying thing histologically with this polyp is that it came back as having focal high-grade dysplasia. So potentially there with this polyp, potentially carcinoma sequence, starts to ring alarm bells. This is the area left after the polyp was removed, and again it looks to be completely removed, but because of the recurrent nature and the piecemeal removal, again an early view of the area was sought. So if you want to move on again, Paul.
I have.
So this is now the appearance in August of last year. So again, 3-4 months further on, the polyp has recurred. And if we move on to the next slide, Paul, please.
I have.
And so we attempted at this stage to do a further polypectomy. But as you can see from that image, demonstrates quite nicely, this particular polyp won't lift. Now, potentially there are two real reasons why this probably happens. One is it may be scarring because of the recurrent nature of the previous polypectomies and the recurrence of the polyp and causing scarring of the area. The other one is the potential malignant risk. So this has been tattooed and biopsied. The other thing that I wanted to mention, as I've already said, he previously had a left hemicolectomy. If we go on to the next slide, Paul.
Done so.
This is an image of his previous anastomosis. From my perspective, from a surgical point of view, it's very useful to have this so that we can plan surgery and also to advise the patient with regard to how we think function after a restorative operation may be. It's always difficult to judge that. I always tell the patients you can't really tell what function is going to be like unless we actually do the operation. But as I've already mentioned, the less bowel that you have left, the less large bowel you have left, the poorer your function is likely to be. And so what we've done here is that on withdrawal of the scope, with a straight scope, we do a measurement from the point of interest, which in this case is the anastomosis, to the anal margin. And it's very important that you do it to the anal margin because, and be fairly accurate about it, because the measurements, particularly when we get down to rectal tumours, can be very, very important. Shall we move on to the next slide, Paul?
Next slide.
So essentially at this stage, we've got a chap who is now 78, but he's very fit and well. He has a polyp recurrence that's not endoscopically removable. Previously has demonstrated high-grade dysplasia. So at this stage now, we had a chat with the guy actually in the endoscopy room, and felt that the best treatment of him, because of the recurrent nature and the high-grade dysplasia, would be a right hemicolectomy. But the histology from the biopsy of that particular polyp did subsequently return as malignant anyway. So we move on again, Paul.
Next slide. So
in September of last year, he underwent a right hemicolectomy, which showed an histology from that resected specimen came back as a Duke's A tumour. So an early stage. Move on again, Paul.
Next.
Now, as I've already mentioned, the importance of measurement. In this particular patient, it was largely about function and how we may be able to advise him with regard to function. I have seen this patient back twice now in clinic since his operation. He's doing extremely well, and he actually has relatively normal bowel function. In that regard, for a 78-year-old, he's actually quite lucky. But he's doing very well with fairly normal bowel function. The other aspect that I've alluded to is with regard to rectal lesions, and one of the things that we've been doing now for a number of years, although we didn't back in the early 2000s, but we now have one of our standard things is to have MRI staging of rectal cancers. Main importance being that we're getting much better overall result with multidisciplinary team working, and that also includes multimodal therapy. And with rectal cancers, if the patient's going to need radiotherapy, it needs to be given preoperatively. And so if you get your measurement wrong at endoscopy, and you measure the lesion to be distal sigmoid rather than upper mid-rectum, then it can mean that the patient doesn't get the full preoperative staging. So it's very important to be certain the lower margin of the rectal tumour in relation to the anal canal, not the edge of the buttock, but the anal canal. Anything within 15 centimetres of the anus, we would do a preoperative MRI scan with a view to considering radiotherapy preoperatively. So again, can't stress it enough, I don't think, because a lot of endoscopists, medical endoscopists, Paul being a prime exception, but a lot of medical endoscopists, the measurements, particularly with rectal lesions, can be wrong. Shall we move on, Paul?
Yep. Last slide.
Again, why do we do surveillance? Overall, there's a 10% risk at 10 years of developing a second metachronous tumour. The other aspect that's bringing this to light, and coincidentally around about this time, I had 3-4 patients last year very, very similar to this particular patient, over 10 years on from an initial resection. We are getting better in this country at treating colorectal cancer overall. Our 5-year survival and therefore cure rates are better than they ever were. And also the aging population. People would generally die of other factors prior to a second lesion coming along, but we're now operating on people well into their 80s, sometime into their 90s. And so if you think of the peak incidence of colorectal cancer being in the 7th decade, that gives quite a lot of potential for patients like this to be coming along in the future. And partly because of that, but also to put our surveillance into sync with the British Society of Gastroenterology guidelines for polyp surveillance, we now perform them every 3 years rather than every 5 years. So you should have...
Hello? Hello?
Do we have a...
Are you there, Richard?
Can you hear me all right?
I can.
Yep.
So, Richard,
Have you got a last slide about joint working?
All I've got, my friend, is... oh, yes, here's one. You slipped in one that was blank.
Yeah. Yeah, I don't know why there's a blank slide there. I'll hold my hand up and take full responsibility. But there should be a slide just highlighting joint working as part of an MDT approach. As I've already mentioned, Paul and I, with difficult cases like this, we do work very closely together, and sometimes it can make quite a difference when you've got a surgeon and endoscopist together. At our weekly colorectal cancer MDT, we often end up looking at images on the patient's report just to try and make a decision, but it is much easier to actually see it live when you're doing the endoscopy. So with the difficult cases, actually joint working together in that situation, I find very good. And we do personalised care essentially now. As I often tell the patients, one of the reasons that we are getting better results overall with colorectal cancer treatment is that although overall general principles do apply, we do try and individualise the treatment to the particular patient, and thinking particularly around the rectal cancer treatment with multimodal therapy, it does give much better results. So it's individualised care, but with general principles overall that would apply that we've already mentioned. So I hope that helps, and I'm happy to take any questions.
No problem. Richard, I think that's really good, because what happens is a couple of things I'd like to make a point on. One is measurement on withdrawal and where to put your finger on the scope next to the anus, so you know that's where the proximal margin is of the lesion, and as you take back then you note it, and then you can put your finger back on the scope again at the anal verge and continue to come back. That gives you the length of the lesion. But it's very important to measure, and it's very important to see the live images. But I think one of the take-home messages for this, even though that polyp looked like it could be takeable, the histology came back saying Dukes A. Should someone been a little bit more adventurous, they could convert that patient into something more sinister by a perforation that might have ensued by not looking. What's your opinion of that?
My opinion or the audience?
Your opinion.
Drat, putting me on the spot. No, I totally agree. I mean, if a polyp doesn't lift easily, then if you do try and take a polyp of that size off, particularly in the right colon, then you very easily get onto a perforation. The overall thing from there on is that you then have the risk of tumour spread within the peritoneal cavity, because if you've cut through the tumour and perforated the bowel, because you've got pressure within the bowel lumen, that will then literally aerosolise, theoretically, tumour cells and spread around the abdominal cavity. in the early days of laparoscopic colorectal surgery, it got some very bad press because of intra-abdominal and port site recurrence. But that was almost certainly because of the operator grasping the tumour and getting aerosolized tumour cells seeding within the abdominal cavity. So, as Paul says, if you press too far with trying to do a piecemeal resection on a lesion that obviously will not lift, you do run the risk of perforation and tumour spread. Whereas with a formal resection of a Dukes A tumour, you're looking at a 95% plus cure rate.
So what I'm saying to you guys in the audience here, if we've got a senior guy like Mr. Hind, Richard, who's been doing this for many years, been a consultant for many, many years, a guy who I respect, and I don't respect everybody, but a guy who I truly respect, if he's telling you that you are going to put somebody at risk by taking on something that may look takeable, but all the signs are indicating that you shouldn't do it, if your thinking is you shouldn't, don't do it, because you're going to convert this to something more significant. And that is the risk you run. It may look takeable because of its size, but there are things you need to do. Is there any questions that you'd like to ask before I say thank you very much?
What's the role of... Okay, hi, this is Saad Niaz. Biopsy in such cases, where you think the lesion might be removable either by EMR or ESD, do you normally routinely take biopsies in such polyps, or do you think that scarring eventually would make it difficult? That's one question. The other thing is ESD. In patients like these, would ESD have a role where EMR is difficult or not possible?
Richard, did you hear the question?
No, I'm getting a lot of echo from the room, so I didn't really catch it all. What was the question?
Okay, so the question was, what do you think the role of biopsy in this particular incident, and what do you think the role of ESD would? How do you think that ESD would actually, should that be one of consideration? Would that be right, Saad? And that's a question from Saad Niaz. Should we be doing biopsies at all? Okay. Right. So what the question is, with the risk of scarring, and before we take off a flat lesion, what's your standing on biopsies? With a view that we could actually go to ESD or EMR?
I mean, as Nick White, one of our colleagues, says, take polyps off, we don't biopsy them. I think it can be a difficult judgment call. I think particularly if it's a first lesion, if we go back to the one in 2012 or whenever it was, that was completely removed and histologically removed, and that did look quite polypoid, then in that situation, I think, absolutely take the polyp off, and usually that will be the end of the problem. With a sessile polyp, I must admit, I do get a little bit nervy about the piecemeal removals. However, it doesn't appear to be a problem. The only issue with the piecemeal removal, and I think this case demonstrates it all extremely well, is that he's not actually come to any harm by the removal of a polyp that lifts easily. I think the issues, as we've mentioned, tend to arise if the polyp's not going to lift. And there's always been this, it seems to be more of a theoretical thing with cancer seeding within a polypectomy area and that sort of thing. It doesn't appear to be a problem. And again, thinking back to the very early days of endoscopy, if you had a distal lesion, should you stop when you get to the distal lesion just in case you rub cancer cells off and cause seeding at a different site? And I think history is telling us that that's not a problem. So I do think overall, if a polyp is removable, it is better to do so, because that, in many instances, will be all the treatment that the patient needs. Does that answer the question?
It does, my friend. Excellent. Any questions for him? Oh, just one more.
The reason why I asked that question was because a lot of times people who are doing colonoscopies don't do EMRs, and so if they suspect something that obviously that needs removal and requires EMR, the point I was trying to highlight was that it's best if they would send somebody else without actually biopsying.
What Saad is doing is something similar to you, suggesting what yourself is saying. If the person doing the procedure hasn't got the skill set or the ability to remove that polyp, Richard, should they biopsy a large flat polyp, or should they leave it alone and bring it back to someone with the skills that could more accurately assess it and deal with it if it was needed to be?
Yeah. People who don't have the skills do tend to biopsy, and I think that's reasonable, because if you're going to do a formal resection, you're not going to do a polypectomy. But I do agree, it's like the setup that we have is that that you do, Paul, with Badri, the difficult polyp MDT, so that photograph, biopsy, and then it can be discussed by experienced polypectomists and a repeat procedure before. But a biopsy basically won't do any harm. Theoretically, one in however many thousands or whatever, it might theoretically cause a problem. But in practice, for the individual patient, it will add information such that you're not going to try and remove the polyp anyway.
That's excellent, my friend. Any other questions? Richard, I'd like to thank you for taking the time out. That was excellent. It's thought-provoking as always. I'm going to Ireland.
You're very welcome.
I'm going to Ireland tomorrow afternoon, so I'll catch up with you when I get back. But I will give you a call.
Lucky chap.
You look after yourself, boss.
Right. Okay.
Thank you very much.
Yeah. Enjoy yourselves.
Thank you.
You're very welcome. Bye.
Bye. So, what Saad is talking about is that should you biopsy or not biopsy? Flat lesions, Richard is one of these guys that's very pragmatic. He's going to say, if you took a biopsy, he's not going to kill you. From my point of view, if you took a biopsy, I'm going to ask you why. Just bring them straight back. I'll see them within 2 weeks. Now, if you know that you can bring them back within 2 weeks, I don't mind you taking a biopsy, because anything within 2 weeks, it's not going to cause me a problem. But if you can't bring them back within 2 weeks, I'd rather you just leave it alone, unless there's a prominent area that you can biopsy. It's not going to add much to it. What you're going to do is just delay the treatment for a short period of time, and that's what he's saying. Should it come back and show something else, then therefore you've cut that 2-week delay out. But if you were to do it in his eyes, he's not going to tell you off. If you were to do it in my eyes, if you got them back within 2 weeks, I'm not going to say a damn thing. What about you, Sad?
My Japanese colleagues tell me, they said that they say that we prefer, if there is a lesion that you want us to take out ESD by, and it looks endoscopically something that needs to come out, whether you got all the information with the MDI or not, they prefer that
You leave it alone.
not be biased.
I think that's true in general. Normally, unless you are, you are